right. Hello, everybody. It's Lauren here. I have a repeat guest, a three-time repeat guest now, because every time we talk, we realize that there's so much more that we need to discuss. So Dr. Emily Levy is back with us today. She is from the TMJ and Sleep Therapy Center of New Orleans. And we've talked about TMJ. We have talked about some other issues that she sees a lot, but today we're going to be really honing in on sleep and what are some of the things that we as individuals need to look out for, parents, but also providers. What are some things that they need to screen for so that they know if this patient needs a referral to someone who specializes in sleep breathing disorders.
Yeah.
So thank you for being here, Dr. Levy, again.
Yeah. No, this is good. This is such good awareness. I know we talked about this, last time and then in person a couple weeks ago. Like, this is such good awareness for the community because a lot of the time, like you and I have discussed, people assume that whatever they're experiencing is normal because it's common.
Yep.
It doesn't make it normal. It just makes it common.
Exactly. Yes.
So we need to be back, in our, just take a step back in our evaluations and our screenings of like, okay, am I just seeing a ton of people with the same issue? Mm-hmm. And maybe, or is it that all these people are really sick? And that's, in my world, more of what I see is that, people are sick, right?
Yep.
It's not just like we all have this same quirky thing wrong with us.
Right.
And so that is, I think, such a component of the outreach that the TMJ and Sleep International group is trying to do, because we go to different, lunch and learns or speak at different courses or whatever, host courses, because the more, and this is what Dr. Olmos's thought process was, this is why he started TMJ and Sleep Therapy International, because he realized that he could only treat the people in his office. Yep. Even if he worked 24 hours a day, 7 days a week, he would still only see those people, versus if he trained other people and then developed these centers, that we could also do that in our communities. And so that's why these screenings and these kinds of conversations are so important, because otherwise, how do they know?
And you don't know what you don't know.
And like we talked about, this is not stuff you learn in medical school. This is not stuff you learn in dental school. This is, you have to go find it yourself. And it is a rabbit hole in the sense that once you start, you just keep digging, but and you realize how much you don't know, right? How little you were actually taught. So from a sleep perspective, I think it's important to separate adults and kids, because symptoms, some of them are similar, but some of them are different. And we treat those things differently. I know we talked a little bit in our first podcast about development and kids and growing and those types of things. And that still holds true for sleep breathing issues. I think I told you in one of these chats that or maybe it was in person, I don't know, my 5-year-old had moderate sleep apnea. Yeah. And I kind of found it on accident. Using another test that I was like, oh, let me see if this will work for my other patients. Let me try it on her first. And she didn't really have the classic symptoms, right? She had a few little things where I was like, could that be, or is it just a fluke, right? And I was monitoring it, but I wasn't convinced yet. And so I screened her with this other tool, and I was like, oh dear, you do have a problem. And so that was in the end of June. And then I started treating her in the end of July. I took a follow-up study in the end of October, and her apnea-hypopnea index, which is, we'll talk about that a little bit today, not the only thing we look for in sleep, but a baseline of some sort, was 5.9, and now it is 1.1.
Wow.
In 3 months. So, and we're still doing a few other things and tweaking some other things. So I expect that to be under 1 by the time we're done. We'll be normal, but it doesn't take long to get legitimate change and to get legitimate results. And so we're talking, like I said, about kids. It's a little bit different than in adults, because in adults, most adults are like, I look the way I look. I don't want to do anything that takes a long time or is invasive. I just want relief. I want to wake up and feel good. And so that's a different conversation where, you can still make some bony changes in adults, no question, but it's not typically enough of what they need. So it's important when we're talking about sleep to talk about like where airflow gets obstructed.
Mm-hmm.
Right? Because if you don't keep those points open, you're not really going to make any change. So the first point of airflow obstruction is the tip of the nose, the nasal valve. It's where your nose kind of naturally pinches in, but on the inside. We talked a little bit, I think, in our TMJ lecture that actually makes you 7 times more likely for oral facial pain as well. So if anybody wants to know more about like how it overlaps, we talked about that last time, how if we can't breathe, our head posture changes, then we get micro traumas to the jaw joint from the musculature, and we get in this cycle. So the breathing is the number one component, but it's also the first thing for life, right?
Yeah.
Like if you can't breathe, you're going to die pretty quick. So the first point of airflow obstruction is kind of right here at the tip of the nose, that nasal valve. Then inside of the nose, so turbinate, septum, concha bullosa, those types of things. And then soft palate and base of the tongue. So sleep breathing disorders are neurologic and anatomical. And so we have to be able to manage both at the same time. The overarching similarity, I would say, between the kids and the adults is that everything that we're doing is being done to keep those 4 points of obstruction open, right? To decrease parafunctional activity, like we talked about before, nutritional kind of supplementation and guidelines to help decrease inflammation. But we have to be able to neurologically stabilize the airway as best as we can. And so the bite position that we take is a little bit different, whether we're treating adults or treating kids, different than just yanking a jaw forward or just expanding, because we're doing that neurological 3-dimensional component to stabilize the airway and in turn keep the jaw joints stable too, right? So it kind of is a 2-for-1 situation. So in kids, we talked a little bit about this, I think, in the first podcast about just the cranial development and the cranial change. But in adults, we use oral sleep appliances. And so sometimes, there's a patient who's super severe, or the type of collapse that they're having necessitates a hybrid therapy where they have an oral appliance and a CPAP, just a nasal delivery of a CPAP. Every once in a while, you get a patient like that. But the vast majority of people are super successful with oral appliance therapy. So when we're talking about, and I should make a note while I'm talking about the appliances, we do not make oral appliances that pull the lower jaw forward. The centers actually put a paper together on that and showed teeth, in what dentists call CRCO. So when your teeth are biting together in maximum, intercuspation, the position of the jaw joints and the stability of the airway, or the size of the airway. And then the same patient with their joints in a phonetic neurologic position, what their joints and airway looked like. And then the same patient in what's called a George gauge position, which is those traditional sleep appliances that pull the lower jaw forward. And what it found was, in the George gauge position, the airway was actually smaller and the joints were dislocated.
Oh, wow.
So in the neurologic position we use, and why we believe so strongly in that, is that the joints don't get dislocated.
Right.
We're not creating a joint problem if we don't already have one, and we're not making one we already have worse. We're stabilizing that and stabilizing the airway. So everything is as neurologically neutral, basically, as it can be. So when we're talking about screenings and symptoms in adults, everybody's like, oh, if you snore, that's the biggest thing in sleep apnea. And you can't have sleep apnea if you don't snore. And that's a common misconception, because sleep apnea, the definition of, is a cessation of airflow that decreases, depending on how you quantify it, decreases your oxygen saturations 3 to 4% for 10 seconds or longer. That's what the AHI number tells us. In a suffocation event, you're silent. You're not snoring when you're suffocating. You're quiet. Right. And so, snoring is a common sleep apnea symptom, but it is certainly not the benchmark for whether you have it or not. And so that's a super common misconception that I think a lot of patients internalize, like, well, I don't snore, my partner doesn't snore, my kids don't snore, therefore they don't have apnea. My daughter didn't snore. She had moderate apnea. So,
but if you do snore, you definitely have it, right?
Not definitely. You can have some other things. So there's a bunch of different types of sleep breathing disorders. It could be more of an upper airway resistance syndrome. It could just be a functional breathing problem where you're not breathing effectively. Yes, it should be. If you snore, though, you should be screened for and tested for it, right? It's not a if then, but it is a highly comorbid symptom, right?
Got it.
So In adults, like I said, snoring, that goes with the kids too. In American Academy of Pediatrics says every child who snores should have a sleep study.
Yeah.
They do not all abide by that guideline, right?
Yep.
But that is the guideline. So in adults, other than snoring, we sometimes have daytime sleepiness, hard waking up in the morning, waking up in the middle of the night to go to the bathroom, insomnia, tossing and turning, restless leg syndrome is a big one.
Okay.
Patients who also struggle with sleep, though, remember with the overlap, tend to sometimes wake up with like morning headaches right in this area here, right in the temple region. They can have neck pain from the forward head posture to accommodate for the breathing disorder. Right. Some shoulder pain, same thing. And then bruxism, that's one that we see also in adults and kids. Bruxism, or the grinding of teeth, is actually under the umbrella of a movement disorder, like a restless leg syndrome type situation.
Oh.
And in the research, especially in kids, but in the research, the masseter muscle activity and bruxism, sleep bruxism, masseter muscle activity, is preceded by a suffocation event in a lot of the incidences in children especially. It's actually higher incidences like that in children than in adults. But we should always be looking for, why are we trying to hurt our teeth? Well, because if you can't breathe, you're going to die, and your brain will sacrifice whatever it has to sacrifice and compensate for whatever it has to compensate for to keep you alive, right? That's how you're designed. And so if that means that you're going to wear out your enamel trying to open your airway, that's what it means.
Okay. So that's what it is. Okay, that's interesting. So the teeth are grinding in order to try to open up the airway?
In a large part. You can also grind or clench because you're in pain, right? The chronic pain, chronic dystrophy situation can also cause some of that masseter muscle activity. But again, the people who grind should be screened for sleep breathing disorders. We should not be wearing down our enamel, flattening it. That's a in dental school, you're taught that that's just some people do it and make everybody a night guard. Well, the problem with night guards is that the research tells us, and so many adults have had this happen, right?
Yep.
You grind your teeth, here's a night guard. Well, if you're grinding your teeth because your airway is compromised when you go to sleep, then we're putting this piece of plastic in your mouth that's just made to some arbitrary thickness.
Right.
Because the way night guards are made is you take an impression, you send it to the lab, everybody's gets made to about the same thickness. You come back, the dentist grinds on it a little bit, maybe, and then it goes in your mouth. But there is nothing neurologic about the bite that is taken.
Yeah.
It's just a standard, this is what we make, right?
Yeah.
And so in the research, if you have a sleep breathing disorder and you're grinding your teeth and then you get a night guard and it's not a neurologic component to it, then 40% of the time, sleep symptoms get 50% worse. So you're actually compounding your problem. You can still grind the heck out of a night guard. It's not going to keep you from grinding.
Right. It's just protecting your enamel.
It's just protecting your enamel. It doesn't do anything for the why you're doing it, right? In fact, it can make you worse. So exactly. So that's another component to this where it's like, okay, in adults, man, if you've got a patient coming in who's like, I've gone through 6 night guards and I've done Botox for the grinding. And some people, if they have a bed partner, especially, they'll say, oh, my husband says I stop breathing, or my wife says I stop breathing, or I wake up gasping. Not normal. Okay?
Yeah. Yep.
Not normal. But there's also something called the Epworth Sleepiness Scale. And that is, if you give it to a patient, that is indicative of, their quality of sleep. Yeah. But if you give it to a spouse or a bed partner, they're usually if you ask them to rate the same, they're usually like 10 points higher than the patient, because they notice
they're the one listening to it.
Doesn't, right? Yeah. And it's like, what's your likelihood of falling asleep sitting on a couch or reading a book or driving a car or watching TV or whatever, but after a meal. But other people notice things about you more than you notice things about you, right? Because it's your normal.
Yeah, for sure.
And that doesn't necessarily mean it is normal, but it's your normal. And so you don't think about those things the same way. But some of the other things that we see a lot in patients with sleep breathing disorders in adults, we can have bad breath. Halitosis, that actually can happen in kids too, because your mouth breathing and everything's getting dried out overnight. Your saliva is naturally supposed to decrease in production overnight, but then when you compound it by mouth breathing, bad breath, higher rate of dental decay. So in kids and adults, if you're constantly going to get fillings or crowns are failing or things are failing, we should ask why, right? Because it's not my patients who need dental work. I know that at some point they're brushing their teeth. Do you know what I mean? It's not, it's not a complete neglect,
right?
So much as it is, especially in our community, right? It's not complete neglect sometimes, but so much of it is function. And are we breathing appropriately or are we not breathing appropriately? I mean, that's a huge problem. Abfractions in adults and scalloped tongues in adults. So sometimes an adult will stick their tongue out and it looks like little seashell indentations on the edges of the tongue. That's like a 70% indicator of a sleep breathing disorder.
Oh my God, I have that. Well, I mean, I have Hashimoto's, so I know you can get it from that too. But yeah, I'm going to be my husband and I are coming next after the kids.
So that's awesome. You're like, yeah, that's me.
I know, I'm like, check.
Coated tongue. So when the tongue, again, in kids too, when the tongue is stuck out and there's like that little white kind of film on the tongue. If we have crowding or that high vault, again, we live here. So cathedral shaped ceiling to the palate, less superdome shaped ceiling. Periodontal disease, dentally, huge crossover to sleep breathing disorder. Because of the way we have to breathe and the mouth breathing and the inflammation in the gum tissue and those types of things. Open bites, over bites, dental crowding. The other thing too, that in dental school you're taught, this is one of my favorite phrases that I've ever heard in school, was a variation of normal. It's like, that's not really giving any information, right? No. Anyway, it's the mandibular and maxillary tori or buccal tori. So some people, a lot of people with sleep breathing disorders have extra bone on the tongue side, but underneath their tongue or in the middle of their palate or even on the outsides of their cheeks on the top. It's usually on the top if it's on the outside. And what happens is, again, it's all compensatory. The tension of the muscles from clenching and grinding, because you can do that up to 5 times harder than you can when you're awake. When you're sleeping, flexing those tissues and flexing those bones. The bone has to grow to withstand the force. And so over time, it just starts to deposit more bone. And so then you get all these like lumps and bumps underneath your tongue, in the middle of your palate, and sometimes on the outsides of your cheeks, by your cheeks. Again, highly indicative that there's some parafunctional habit happening. And then you got to figure out, why is it happening? So we refer to say, hey, do you have a sleep breathing disorder? If you do, that explains that. If you don't, we got to dig deeper on, are you in pain? Is there a chronic dystrophy problem, right? There's a reason for it. You don't just develop all this bone for nothing, right? It's always a cause and effect. Always, always, always. In kids, kind of on the counter, a lot of the things I just said overlap. So the repeated awakenings at night, your kids getting out of bed and coming in your bed, 4+ nights a week, or honestly, any nights a week is too many, but you understand. Grinding of their teeth, the bruxism we talked about, bedwetting, huge.
Yeah, I was going to ask you about that.
Huge component. And so I have so many kids who have bedwet and have a breathing issue that was causing it. They've been to the urologist. They've gone to all of the specialists. They've tried to figure out if there's something intrinsically wrong with their bladder. Everybody's like, you're technically fine. They'll grow out of it. Well, that's absurd because if they're not breathing, nobody ever looks at the airway, right? If they're not breathing, then they're not going to grow out of it. They're just going to compensate more for it.
Yeah.
And we don't want that, right? We don't want kids to compensate forever. You would like them to just be functional.
Well, and then they're still left with the breathing disorder, even if they stop wetting
the bed, the breathing disorder didn't get better. Exactly.
Right.
Speech difficulties. That is huge for a lot of our kids. So I'm lucky enough. I mean, you've met her, my speech therapist who works in our office.
Yes.
Fantastic. Does our myofunctional therapy, does some feeding therapy, does some speech therapy. She does a great job. My best friend is also a speech therapist. She's in Baton Rouge. And so she actually comes in and guest lectures with the courses that I host, and the courses I teach on how speech and feeding is related to breathing. And so we've treated kids together. She and I have treated a few kids together where we have like good data on speech or pre-therapy speech articulation and their guidelines and their benchmarks and, what percentage these kids are.
Right.
And post. And so we've seen there was one little boy, we present on him, so he's fresh in my mind. We started treatment when he was 4. It was like the week after he turned 4. And his speech articulation improved 2 standard deviations in 3 months.
Wow.
But we grew him, right? Yeah. If the palate is not developed enough, the tongue can't make the speech sounds the same way.
Right.
And so either it's going to be distorted or kids are going to compensate. It's one of the two, right?
Yeah.
And so just developing the palate has the articulation improving 2 standard deviations in just a few months.
Right.
So that's huge for a lot of these kids. And remember, Dr. Christian Guilleminault, I think I had said this, I don't know, I gave another webinar on Friday, so I can't remember if it was with this or that, but Dr. Christian Guilleminault said that sleep breathing issues in non-obese children are a disease of dental facial orthopedics. So if we don't fix the orthopedics, we're never going to make significant change to the sleep disorder.
Right.
And in speech, if your structure of your maxilla is improper,
right,
then your sound's going to be distorted.
Right. Right.
So it goes hand in hand. Same thing with some of the feeding things that she sees. We've seen, again, overlapping with that. Forward head posture, again, that's a kid and adult thing. The mouth breathing, the open bites, the crowding, the high vaulted palate, bad breath. Kids tend to have more enlarged tonsils and adenoids than adults would. That's a big one. I think we talked a little bit about, the risks of just going to the ENT and getting tonsils and adenoids out. Did we talk about that we triple our relative risk with tonsillectomy for like COPD, allergic rhinitis, upper airway disease, and then double it in adenoidectomy. And there was a huge Taiwanese study that showed 68% of kids relapse 6 months to 3 years after TNA because their underlying breathing issue wasn't treated. They just removed the alarm system. They removed the smoke detector. They didn't put out the fire, right? And so
and then the tonsils can often grow back, right?
They can if it's not. Yeah. A lot of ENTs do not do a complete enucleation of the tonsil because of the risk of hemorrhage. And so there's a little layer that's left most of the time, right? And so, they can recur, which is kind of, why would you go through all that?
Yeah. A surgery with anesthesia. And
it's not a comfortable surgery. It's not something that people are like, oh, let me sign up for that.
No, it's miserable.
It's miserable. And then behavioral issues. So ADHD, huge overlap with sleep. Most kids with ADHD have never been screened for a sleep breathing issue. And the studies are coming out. It's changing frequently. I just presented into one. I think it was like up to 30% of kids with ADHD actually have a sleep disorder.
Wow.
So if I'm remembering my study correctly, just take it with a grain of salt, but it's a significant percentage. And so it's like, okay, that seems high considering we're not screening all of those people. Right. Same thing. And this is adults and kids. Same thing with anxiety and depression. We see a huge decrease in the GAD-7 and the PHQ-9 with better sleep. But if people are struggling with anxiety and depression, we need to be talking to them about their quality of sleep, because if you can't rest, you're going to be more anxious. There's no question. Right. Oppositional defiance disorder, same thought process. And then also neurocognitive changes in kids from an educational standpoint and an ability standpoint can be permanent after age 6. So if we're struggling in school, some of them, we're struggling in school, if we're, having trouble attending, if we're studying, but we're just not translating to assessments, those are things where it's like, okay, why don't we take a closer look at the way you're sleeping? Because if you're not getting quality REM sleep, you're never going to convert short-term memories to long-term memories properly.
Nope.
And so that'll affect your performance in school.
Yep. Yep.
Right.
And if you miss those building blocks when you're little, then it's like really hard.
It's hard to catch up. It's hard to catch up. Yep. The other things just in general for both, again, respiratory infections, hypertension, type 2 diabetes, obesity, obviously.
Yeah.
GERD is a big one. Nighttime GERD. That's a big one. Because of the negative pressure that builds in the thorax, pulling up that stomach acid once you finally do take a breath. Cardiovascular disease. We see a lot of adults who have AFib overlap with their sleep breathing issues.
Huh.
And then asthma and respiratory infections. What is asthma? Asthma is an inflammation of the bronchioles, right? So why are we having the inflammation?
Right? Nobody asks that question.
Nobody asks that question. We're just going to give everybody an inhaler, but we're not going to ask why we have the issue. And there are certainly some people with allergies, no question. Okay. But if we're not filtering air properly through our nose, then those allergies can be exacerbated.
Right.
And so minimizing the amount of reactivity we have is never a bad thing, you know?
Right.
Never a bad thing. So that is something that I think is at least an overview of, okay, what are we seeing? And I even see kids sometimes with the extra bone, and in kids, it's usually in the palate. If I see it, it's the extra bone, but we see it often. Tongue ties and things like that obviously play a role, but not the whole picture. And this is something I lecture on ad nauseum. I teach a course on tongue tie for a laser company, but I also got my fellow in oral facial myology, so I could say these kinds of things without people being like, you just don't know. That providers, put these blinders on when they're talking about tongue tie. And it's like the tongue tie is just going to be this magical fix for everything. And I will tell you, 75 probably % of my adult patients, if I just had to pull a number out the air, have a tongue tie.
Wow.
And it's because of the way they developed and all these things.
Yeah.
But the amount of adults that I actually have to intervene for their tongue tie is so very low.
Yeah.
Compared to the percentage that have one.
Yeah.
Because everything else is out of whack too.
Yeah.
And so if I fix the nasal breathing and I decrease the inflammation in the jaw and I stabilize the airway, the amount that the tongue actually affects at that point becomes less and less and less and less.
Right.
And so, sometimes we have to do surgery on tongue tie. It's not a giant deal. It's not that hard. Healing goes really well. It's not a big deal.
Yeah. Right.
And it can help things, but we can't just look at that as if we just release this tongue and do some myofunctional therapy, their breathing disorder goes away. No, because we still haven't moved the bone around, right? Or we still haven't used neurology to stabilize anything. It just freed up some tissue and made it work better. And yes, you can have improvement with myofunctional therapy and things like that for sleep breathing disorders, for snoring, but it's not definitive. It's more of an adjunctive therapy. So if patients have been told you need myofunctional therapy or you have a tongue tie or whatever, the amount that by itself is going to translate to actual symptom improvement is low.
Yeah.
Right? You're going to get some noticeable change, but it's not going to be definitive. Right. And the other thing too, because there's a few different types of sleep breathing disorders, another one of the more common ones that we see is something called upper airway resistance syndrome.
Okay.
It's affectionately known as young fit female syndrome, where
I've never heard of this. Okay.
You have a lot of the same symptoms, fatigue, restless sleep, daytime drowsiness, difficulty waking up in the morning, as you would with a sleep breathing disorder. But it's more of a nasal component than a complete collapse of the airway component. Okay. And so it's more of a partial obstruction type thing or a limitation to airflow than it is like you just stop breathing completely. But that is something that from a nasal perspective, depending on age, depending on symptoms, we can still stabilize and then also direct for appropriate either nasal breathing exercises or ENT for nasal surgery to move the bone back where it belongs if it is impeding appropriate airflow.
So how does that develop? Like, how does someone develop that condition?
So it's really back to the growth, right? Okay. It's back to, in utero, that tongue has to sit up in the palate and they're swallowing in utero. Babies are moving that tongue around, swallowing. Tongue tissues form about 6 weeks in utero. So hard palate's about 10 weeks in utero. And then they're working together from that point on to develop the face. once we're born into this crazy environment, right? Where the air we breathe and the food we eat and everything is poison. I know we talked about that before. And so it's not conducive to growing a face. Mm-hmm. And so if the tongue, even if the tongue isn't tied, if it's not able to function appropriately because of the environment, then we're not going to get normal development.
Okay.
And so again, if that palate is elevated or had blunt force trauma to the nose or just some soft tissue inflammation where we're really struggling with, something environmental, any and all of those things can be a component for upper airway resistance. It does make you more likely at some point to have a sleep breathing, sleep apnea, because it's all kind of on a gradient. But upper airway resistance, we see more as like a nasal breathing limit to airflow component than a full collapse.
Okay.
But it'll give you a lot of the same symptoms, and it very commonly affects younger females who exercise. They're generally healthy, but they still are exhausted. So that's a thought. And then the other thing we were talking about, just for provider purposes, like for screening tools, I'll give you a lot of info on adults, but what we're trying to do for the kids is get a screening tool where it's just like these are some invalidated, right?
Yeah.
These are the top things where if you're seeing a kid and you're looking in their mouth, if you see something like this, that's a red flag. We currently right now for sleep screening in kids, there's the Bears sleep screening tool, which is not validated, but it's helpful. Dr. Judy Owens, who's a professor at Harvard and at Boston Children's, she developed the Bears for a screening for parents and kids. And so it's separated by age of like, if you're this age, this is your column, this column, depending on how old the kids are. And then it asks parent questions, but then it also asks kid questions depending on their age. And so it's nice to see what the kids think about, in adults, we do the Epworth, the GAD-7, the PHQ-9. But in younger kids, they're too young to do the PHQ-9 and GAD-7. And then the Epworth is not quite the same for them, right? They're not driving a car. So what do you do to screen? So the Bears is good for getting kids input. Actually, one of my very favorite ones, I had a little boy who it says like, do you have any problems going to bed? And he put no, he wrote in, no, sometimes it just takes me a long time to fall asleep. And so you see how they think about it, right? So that's a really helpful one as just a screener. But the pediatric sleep questionnaire, the PSQ, that is validated. And so that goes through nighttime symptoms. It goes through daytime symptoms. It goes through some hyperactivity stuff. It goes through all kinds of things. Where it's asking parents to yes or no, even like, have you stopped growing at a normal rate since birth? Do you snore more than half the time? Like it's like 20 or so questions. But a more detailed, do you act like you're on the go or fidget? All of these types of questions where, that is validated for, okay, if you have this many yeses, that's a big red flag too. I take the number of yeses with a little grain of salt because I'm also looking clinically in their mouth. I can see you're underdeveloped. So if you don't if you're a couple short of the technical amount of yeses where you'd be referred, but I see things in your mouth that are concerning, I'm going to refer you anyway, right? Like we still have to use our common sense. We still have to, we can't just be like, well, you didn't make the cut. Like that's not a good benchmark for patient care. But again, for more pediatric type offices, pediatricians, those types of things, they need something kind of quick. Right? But not all of them know what they're looking for. And so I'm going to see if I can share it. To be determined. Let me see. Oh, look. Can you see it?
Yeah.
Wow. I'm never good
there
at
we
computer
go.
stuff, but here we are. So look at me go. Excuse me. So this is kind of what I was talking about with the symptoms and the signs and all of those things for adults and for kids. But this, I'm going to see if it'll let me. Here we go. This is in the process of being published. This is the PCSS research project. So the American Academy of Craniofacial Pain worked together with Dr. Judy Owens. That's the one in the middle. That's the one who did the Bears sleep questionnaire I just told you about. Dr. Edmund Liam, who's the TMJ and Sleep Therapy Center in Vancouver. And then Dr. Rakesh Bhattacharjee, who's the associate professor of pediatrics at UC San Diego, and he's at Rady Children's. And so this is what they came up with. And it's a really nice visual for, hey, if you're looking at a kid and they have this, and all of the little side sources are right there, right? What the dental arch morphology in kids is with sleep disordered breathing, what natural head posture, upper airway morphology, and obstructive sleep apnea look like, the relationship between craniofacial morphology and obstructive sleep apnea, like all of the references are right there. But then they have, and Dr. Olmos worked on this with Dr. Ramirez, and again, Dr. Owens, Dr. Liam, but putting together this visual is going to be super, once it's published, it's going to be super helpful for providers to be like, hey, if we have these things, this isn't we're going to wait till they're 12 years old and just straighten their teeth.
Right.
This is a problem in their day-to-day life right now.
Right.
And we need to do something to intervene for them. Right.
Hopefully this is going to like pediatric dentists too, huh?
Yeah, that's the hope.
Yeah.
That's the hope is that in an ideal world, we can, again, like I said at the beginning, get the message out. Even if you don't want to treat it, you don't have to.
Right.
There are people who do. There are people who are willing to. Fantastic.
Yep.
I don't want to do a bunch of fillings on kids.
Right. It's not your jam.
If I never did another filling on anybody, I don't want to do it on adults either anymore. But if I didn't, truly, that's okay if we're fixing function, right?
Yep.
And if we're fixing function, we should be fixing some of those dental issues.
Yeah.
Right? Because we're breathing better. Our lips are closed. We're not drying out our mouth. All of these other things. Yeah. Not that we're not going to have any, but it will significantly decrease the incidence. Right. And so that's the goal is like, hey, if we're seeing this, pediatric dentists, and I don't blame them. It's like, oh, well, I'm going to send this patient over and then they're going to do their dental care. Absolutely not. Right. Same thing with adults. Oh, I don't want to refer this patient because they're going to do, their next dental care. They're going to the adult's going to go over there for cleaning. Never have I once told the patient, don't go back to where you came from.
Right. Right.
Please go back where you came from.
Please go back. Cause I don't want to do your cleanings.
Happy to help you when you need it.
Yeah.
But please go back to your normal provider, right? In your dental home. And the same thing, with orthodontics, and I know we talked a little bit about this, but just the very, again, myopic thought process if we're just going to straighten teeth.
Yeah.
Right. And I lectured on some of this on Friday that orthodontists, they publish this about themselves, that they really can't identify mouth breathers.
Yeah.
They don't think about that in their treatment planning on the whole. Okay. There are some, don't misunderstand. There are some that are doing this, but on the whole, that's not a main concern for them.
Right.
And they said, in 8 years, we expect orthodontic treatment to relapse. Right. We expect teeth to go back where they came from. Even if we put in fixed retainers, we still expect it. They said the ones in the mandible are better. The ones in the maxilla may not actually make any long-term difference. That's what the paper says.
Wow.
And it's like, okay, again, we got to ask why.
Yeah. Yeah.
And then we went from a kid with a breathing issue to an adult with a breathing issue.
Yep.
And their teeth are still crooked.
Yeah.
But there's still a functional deficit. And so that's the thought process. So those would be like I said, we could talk about just the main things. Those would be the main things. We're like, hey, if you see a patient with some of this stuff, there's probably something else underlying it that needs to be at least screened for or addressed. And the amount of times, because again, it's a hard thing to talk, especially in an adult, it's a hard thing to talk to them about because you're like, well, if you just say, how do you sleep? Some people are honest and they're like, I don't sleep well. Some people truly believe they sleep well.
Yeah.
Because it's the only way they've ever felt.
They have no frame of reference.
It's the only way they've ever felt. And so some people are like, oh, I do wake up a few times a night to go to the bathroom. You're like, okay, well, what if you didn't have to anymore? Right? Like, what if you could just sleep all night? Those people that know, they're usually more like, okay, let me get screened. But again, there are some people who are like, I'm sure I'm fine. but they don't know, like you can be looking at a ton of clinical stuff and feel like something's wrong, but they're like, well, I feel okay, but they've only ever lived in their body.
Yep.
So sometimes you just have to be a little more forthcoming with information about what you're seeing, and then let them go home and research it, you know?
Yeah.
And be like, oh no, you know, this is related to this other medical issue you're having or whatever. Because that's a huge component, is that people can't separate themselves from their normal.
Yeah.
And it makes sense, right? It happens in kids too. I mean, we talked about this, happens in kids too. They don't think about pain the same way. They don't think about sleep the same way because they only know what they've lived.
Right.
And so making sure that we're at least able to give information to a patient is important. And also that we're screening properly to know when we need to divert or say, hey, you know what? It's worth you going to get this checked out. If it's nothing, great. You just got information. But if it is something, wouldn't you want to know if you're suffocating?
Absolutely. Absolutely. And it's crazy how little providers know about this. You know, I mean, like no one has ever told me why one of my children has a crossbite and why the other one now has an open bite. Like no one's ever told me that. I knew that they had them, but I thought it was just like, oh, one day they're going to get braces and correct it. Right. Like no one ever told me that. And I stumbled upon you and started like asking questions, like while we're talking about a patient, it's like, okay, wait, let me ask you about my kids while I have you on the phone. And like, lo and behold, there are a lot of issues, you know, that like I never, and my kids don't snore. Like I would have never known, you know, it's made me, it's crazy how much this has changed my intake process with my patients.
That's very
like the questions that I ask, you know,
and it's important, you know, it's important because they're, especially in your case, you're seeing a ton of kids. Getting them on that appropriate trajectory as early as possible makes such a significant difference for their adulthood, you know? And so, I so appreciate what you're doing because again, all of this stuff is comorbid. You know, the ODD and the anxiety and the depression and the ADHD, I mean, all of that is highly, highly comorbid, but also detrimental to their quality of life.
100%.
And so, you know, we need them functioning.
As
best as they can. And so, look, it's not to say that you fix a sleep breathing disorder and like a magic wand, everything else is better, right? You still sometimes need some supportive care or need to work through some things, no question. But it will certainly make it better.
Yes,
and
absolutely.
So, you know, are you going to go from a 0 to 100% in every single kid? Not every single one, because kids have different things wrong too, right?
Yes.
Everybody's a little bit different. And so you have to treat that patient individually, obviously. But if you can make a significant change to that person's quality of life and help their general systemic regulation, that's huge.
Well, and it's hard to get people fully well if you don't correct this piece.
Yes.
That's the other thing.
Yes.
You know, you may not like solve the whole picture by addressing this, but if you don't, you may not ever get to
fighting an uphill battle the whole time.
Yes, forever. Yeah,
absolutely.
Well, thank you so much for coming back again.
Thanks for having me again.
Okay, so even though everybody has probably heard where you are, how to find you, just remind listeners.
So my office is the TMJ and Sleep Therapy Center of New Orleans. It's in Metairie. Our phone number is 504-832-2222. And our website is tmjsleepnola.com. It's also our Instagram handle at tmjsleepnola. And I also have just some webinars recorded on, I got to think about this. I think there might be one on Nuvola's website now because I did one a couple weeks ago for them, Nuvola. But there's definitely one that is stored and has been recorded. It's about an hour and a half, hour and 40 minutes long, on pediatric apnea specifically, and it shows some cases and things like that. And that is on TMJ Therapy Center, CENTRE.com's website. That's our TMJ and Sleep International website. And so the webinar is there, information about my course is in there. They've got good stuff. They've got the information about the adult course too, which is also super important, goes through detailed hows, whys, whats. So yeah, we've got a ton of info on the international website too. And like I said, I do have a webinar specifically showing cases and more research and things like that that's recorded on there as well. So
amazing.
Yes.
Well, thank you so much,
Thank
Dr.
you.
Levy, for being here
Appreciate
and giving us
it.
all this amazing information.
Well, thank you for having me.
All right. Thank you for tuning in to this episode of the Little Brain Campaign podcast. If you enjoyed our conversation, give us a follow on your favorite podcast platform so you never miss an episode. Please take a moment to leave a review while you're still thinking about it. It really helps grow the podcast, and I love hearing from our listeners. See you next time.